Ladies and gentlemen, we're going to start this session, might be last session of this year complex PCI 2020 meeting. This session title is a virtual CRS 6, number 6, and taped live case for complex PCI in complex situation. I'm going to introduce the co-moderator and the co-panelist, and my name is Dvir Park from Asan Medical Center. Co-moderator is Jung-Min from Asan Medical Center. He's now in the Stanford University. I'm going to introduce the panelists and Dr. Euihong from Asan Medical Center, Dr. Ho Ram from Hong Kong, Dr. Michael Lee from Hong Kong, Dr. Wei-Hsien from Taipei. Dr. An, could you introduce the first speaker?
Thank you, Dr. Park. So I'd like to introduce the first speakers, Dr. Kang from Asan Medical Center. They will present the live case interactive with the interactive discussion. Please, Dr. Kang.
Thank you, Chairman. I'm Dr. Kang from Asan Medical Center. I will share my challenging case with left main PCI. The patient is 77-year-old female, admitted for reported angina since 1 month ago. She had a history of hypertension, dyslipidemia, on medication. She had received several surgeries before, and she was taking aspirin, clopidogrel, atorvastatin, bimaceltan, levodopa, and diltiazem. Her physical examination revealed no significant abnormality. ECG showed non-specific FT change, and chest PA was within normal range, and echo showed normal LV and RV size and systolic function without significant valvular abnormality. There was no pericardial effusion. We checked the CAG, and you can see the diffuse tight disease on the RCA and severe calcified disease on left main bifurcation. The circumflex also is very tight, and left main is very calcified. And you can also see the diffuse disease, diffuse calcified tortuous disease on the LAD with severe stenosis on the left main bifurcation. 77-year-old female unstable angina with left main and cerebral cell disease and normal cardiac function. The cabbage was declined by the patient and patron. And we decided to perform the PCI for the patient with unstable angina, and RCA, the stenting was done with Onyx 2 stent, and the problem is left main bifurcation. How would you treat for this kind of the tight main disease with very severe calcification and stenosis on the left main and circumflex ostium?
So, and
this is my discussion point 1.
Okay, yeah. We will have interim discussion point 1, 77-year female and presented stable angina, right coronary artery already treated. This is a distal left main region, trifurcation region. Is how they treat. Is there any comment or any suggestion for this patient? Okay.
So clearly the distal left main bifurcation is gonna probably require an approach because it's a Medina 101, but it's more technically challenging maybe the mid LAD because there's an acute angle, and it looks like there's a fair bit of calcium, but doesn't look severely calcified. So my thought would maybe to treat the mid proximal LAD first, then address the distal bifurcation afterwards.
Is Horam? Any thought?
I agree with Dr. Lee's comment. Maybe the AD is quite calcified in mid-AD part or certain part. I think we can first wire the AD and then do an intravascular imaging. If you don't want to do intravascular imaging, maybe sometimes you can put a balloon and then stent boost. If it's ghostly with calcium, then I will start motivation in AD first, and then we'll go for the bifurcation. For bifurcation, I will choose 2 stent strategy, and we'll use quads in this quad style in this case because the osteal is quite tight.
Yes. Yes, I agree to Dr. Lee and Dr. Lam's opinion. And we planned to treat the LAD first with severe calcified lesion and then treat bifurcation lesion. And fortunately, the big diagonal ostium looks preserved. So we decided to treat the LAD first and perform the crush technique for the left main bifurcation. So I prepared a large bore guiding catheter with a strong back of force, and IVUS would be essential. And I used the JF4 8 French catheter, femoral approach, and wired into LAD with a Sion wire and circumflex with the BMW wire. I tried to treat the LAD first, so introduced the IVUS to LAD, but it was failed. So I had to perform the pre-ballooning at the not only LAD but also in the left main. And because the balloon did not introduce advanced into LAD, I introduced the Godzilla 7 French and performed the ballooning and put the stent Onyx 2.5 with nominal pressure. And something happened. After the stenting at the LAD, and let's do the main PCI, but I could see the severe perforation at the distal edge of the stent. The amount of the LAD perforation was large. And this is my second discussion point. I already performed the predilation with the NC balloon at the left main bifurcation. And the LAD perforation occurred after stenting. How would you treat?
Oh, that's a terrible situation. That's why I recommended give the tips and tricks balloon to use stent boost and then check the calcium, because in this case I suspect even the IVUS cannot cause. And the reason for this perforation is that your NC balloon actually cannot crack the calcium; it just push it outward and then causes this perforation. So the perforation occurred. And it's cast-free, definitely severe perforation. So in general, the principle I think is you must use cover stent. And first of all, you should use a balloon to localize the perforation first. Use a balloon to occlude and then to test if the balloon, for example, can occlude. And then this is the location that you put your cover stent. For cover stent, the delivery may be difficult. Traditionally, you will need to use the second guiding. But however, some new cover stent, the deliverability is similar to usual stent. Maybe you just use guide extension, you can deliver. So you may not need two guiding nowadays. I don't know others' opinion, maybe.
Agree, you can use Biotronic cover stent, only one layer PTFE and one layer of metal.
So how was the patient?
Yes, how's the patient doing?
Yeah, the patient was stable at this time. The vital was stable. So the patient had some chest pain during the first stent implantation, but now the vital sign was stable.
I think first of all, you need to balloon tamponade the lesion first, and then quickly perform an echo and see how much pericardial effusion. It looks to me is a torrential perforation here, so I think the accumulation of pericardial effusion would be very quick. And then prepare the groin for another guiding, just in case it's a torrential perforation. You might need a ping pong guide for you to deliver the stent graft while tamponade the lesion with the balloon.
Yeah. Yes, I agree with your opinion. Fortunately, the patient was stable at this time, but I introduced the 2.5 compliant balloon into a rupture site and then inflate the balloon by nominal pressure, and the perforation was the leakage was stopped. But and we checked the echo, and there was no significant pericardial effusion, and the vital sign was stable. So my first plan was to perform the graft stent or to use the double guiding catheter, as Dr. Lee said, to use the ping pong technique. But the patient was stable at this time, and because we were using, fortunately, the 8-branch catheter, we decided to perform the left main PCI, bifurcation PCI, to avoid the patient the collapse because of the left main ballooning and dissection. So I inserted another wire into diagonal branch and performed left main PCI during while occluding the LAD distal with compliant balloon. And I performed the Onyx 2.75 stenting at the circumflex and performed the balloon crush with 3.0 NC and additional predilation and implanted. And after the circumflex, treating circumflex and the crushing, there was a minimal amount of the leakage at the perforation site. So I did not need to use the ping pong technique and put the left main to LAD stent with a 3.0. And because after this, there was a little bit leakage at the perforation site, I again inserted a 2.5 compliant balloon and inflated and inserted another BMW wire into LAD and performed the post dilation and circumflex rewiring and opening the ostium and performed the final kissing balloon with 3.5 and 2.75 NC balloon while occluding the LAD. After all, I could still see the perforation, a large amount of the leakage. So then finally I implanted the graft stent with 2.8 up to 12 ATM. So this is the final result. And the patient was unfortunately safe without pericardiocentesis, and there was no significant amount of the pericardial effusion, maybe still on the LAD fed. And the circumflex IVUS and LAD IVUS showed good scanner position. And you can see the calcium of the LAD. And proximal LAD was very expanded, and the circumflex opening is well opened at the left main. So this is the final result of the PCI. And fortunately, with the large bore guiding catheter, I could keep going the left main PCI while occluding the LAD perforation site. And this is my final discussion thought. During left main PCI, the patient safety is always the first. Do you agree with my treatment strategy in the present case? And how can we minimize the risk of perforation during complex PCI? And I also want to ask your tips and tricks to treat perforation.
Okay, so this is a very, one of the very complex and terrible case. Any comment regarding the interim procedure? How do you treat this patient if this patient is your patient? Is any comment or any thought?
Okay.
So the doctor,
okay.
Dr. Lam, I have one question to your opinion. So if Dr. Lee, Michael Lee, so if Dr. Gang did the rotabulation first to the LAD, so can you change the whole process or for procedure something?
That's a very good question. One of the potential risks of atherectomy is perforation, especially when there's a 90-degree angle. So there's a risk with perforation with rotation atherectomy, but perhaps it would not have required such high predilatation. So there's kind of a pro and con of both. as they previously mentioned, if you go high pressure inflation, you don't really push the calcium or break up the calcium. You just stretch the vessel where it's normal. So if you can't advance IVUS, that's possibly a good sign telling you that you should consider doing an atherectomy. One thing that I would do is use a compliant balloon, go to nominal pressure, and if it doesn't yield, if it doesn't profile, then at that point, I would consider atherectomy, but I'd be very cautious because of the severe angulation of the vessel. However, the angiographic result's perfect. What I would say is that anytime you implant a graft master or a covered stent, it's very vital to go very high pressure because these stents are apt to stent thrombosis and restenosis. So you really want to go high pressure with the non-compliant, 20, 25, 28, because you can't really rupture after you put a graft master. So high pressure inflation, but IVUS looks like it's an excellent angiographic and intravascular imaging result. So congratulations.
Congratulations for your case. I personally will put the cover stent first, then do the lemon PCI. I think that would make things easier.
Yeah.
Yes.
I think I have the similar comment. Congratulations for your great case. The end result was excellent, but I will probably tackle the perforation first, simply because once you put the complex stenting at the left main, you cannot really predict whether your stent graft will go. That would increase the complexity of the procedure when you see a torrential perforation again and you want to quickly deliver a stent graft, then you might get into trouble. But I understand that since your balloon tamponade result is so good, you thought you might get away without a stent graft. Then you perform intervention for the left main bifurcation. But subsequently, there was a increased perforation again. But personally, I would probably handle the perforation first. Wait for a while for the perforation to heal, to secure before I go on with the left main complex stenting.
Anyway, I'd like to congratulate Dr. Kang and compliment your very calm mind and procedure despite the very catastrophic event. So I think that this would be very important when you meet the unexpected event. But we have to prepare this catastrophic event. So I'd like to move to the second lectures. Dr. Danny Dvir, are you ready? Dr. Dvir is from the University of Washington, United States, very famous for the valve in TAVR. So Dr. Dvir will talk about the Basilica and Chimney techniques in valve TAVR.
Okay, thank you so much. So we're going to talk about the Basilica technique. It's not really PCI, but it's significantly related to PCI and to the Chimney technique. Basically, we know that with TAVR procedures, these are my disclosures, there is a potential risk for coronary obstruction. Coronary obstruction with the TAVR is a relatively rare event. It happens in 1 out of 200 cases, approximately. In valve procedures, it happens in 2 to 3% of cases. In certain bioprosthetic valves, like stentless valves, mitral flows, the percentage, the risk is much elevated. Sometimes it's approximately 10%. And the coronary obstruction is a devastating complication. It's associated with very high early mortality. So we must identify patients at risk for coronary obstruction, and we must prevent coronary obstruction by all means. We used to think that it happened in a relationship that we cannot identify to begin with, but now we know that it's all about the relationship in space between the leaflet that is deflected and the location of the coronary ostium. Basically, we have a new classification of how to define the relationship. There are coronary ostia that when they originate above the plane of the deflected leaflet, and then the coronary obstruction will not occur. If the coronary ostia originate below the deflected position of the leaflet, then it will all depend on how much space we will have after the TAVR. If it's a lot of space, then the sinuses are wide, then coronary obstruction will not happen. If the sinuses are effaced, then coronary obstruction can occur. And also coronary obstruction can happen at the STJ level. This is type 3 anatomy. If the leaflet can go above the level of the STJ, then you need to have enough space both at the level of the STJ and at the level of the sinuses. And we call that parameter that will describe how much gap you have between the deflected leaflet and the wall as virtual THV to coronary distance, or VTC, and you need at least 4 millimeters. Well, very briefly about the Chimney technique. The Chimney technique or snorkel technique is a technique that we described more than a decade ago in order to prevent coronary obstruction. Basically, it came from the fact that it's very tough, it's very challenging to go back to the coronary tree after you have coronary obstruction. It's very challenging because you have a lot of material and metal from the TAVR device and the deflected leaflet. So the concept was to protect that branch with a stent. It's and similarly as if we are protecting a branch, a side branch during a bifurcation treatment, but now our main vessel is the aorta and the side branch is the left main. We need to protect it. So we keep a stent, we deploy the TAVR device, then we pull the stent and deploy the stent in the coronary ostium. But we know now that there are concerns about the durability of doing the Chimney technique. Here is an example of a suboptimal patency of the left main after performing Chimney after a year follow-up. And also the right coronary artery was occluded later on. Then we understood that probably we need to act upon the origin of the obstruction. The thing that is causing the obstruction is the leaflet that deflects when we do the TAVR. And we need to manipulate that leaflet. There were different strategies on how to manipulate that leaflet over the years. Eventually, we decided that the best approach would probably be to lacerate that leaflet. There are several other techniques that use to lacerate other things like the anterior mitral valve leaflet to prevent LVOT obstruction in the lampoon technique, and this is an extrapolation of these other techniques that were developed by the NIH team. So here you can see how the Basilica technique can be effective. On the left side, it's a leaflet that is deflected without Basilica. It really creates a covered stent, like if you just deflect these leaflets. But if you make a laceration over the leaflet and you deflect it, then you create like a triangle. There is like a separation between these two parts of the leaflet, and there could be flow maintained through that area. The technique of the Basilica is, I will need more time to describe it, and you can read about it in our different publications. But basically, it's a transcatheter technique that is designed to create that laceration over a leaflet before the TAVR procedure. And it includes two steps in which we electrify an O14 wire in order to first go through the leaflet and later on do the actual laceration of the leaflet. And after you do the laceration, then there is patency towards the coronary tree. It involves several stages, and that I will not describe them in full. That includes a traversal of the wire, snaring it, and later on performing the laceration, and you can read about it. Basically, this is the first in main Basilica procedure that we performed in Seattle in a little more than 3 years ago. So early on, we were not sure that the Basilica will be effective, and you can see several things that we do not perform later on, like a coronary protection. You can see that there is a guide in the left main with a stent waiting in case there will be an obstruction. There is a pictal waiting in the left ventricle, and there are 2 catheters that go through the leaflet, and during a certain time, they are being pulled while the electricity occur. You can see laceration over the leaflet when the Basilica is performed. Here's an example of a mitral flow Basilica procedure. Mitral flows are very common valves coming for Basilica, and you can see the leaflet of the mitral flow goes up and down. Here's a traversal of the leaflet. You snare the wire, and later on you have 2 catheters, 2 sides of the leaflet. You electrify the wire and you pull. And this is after the implantation of the TAVR device without coronary obstruction. We understood later on that Basilica is an effective tool also in cases of native aortic valves coming for TAVR procedures. And you can see the aortic root and the relationship between the leaflet and the left main, which is relatively close. Leaflet traversal and laceration. And this is after the implantation of the device. And you can understand that the leaflet is very close to the ostium of the left main without coronary obstruction. Approximately 15% of Basilica procedures are performed for both the left main and for the right coronary artery. These are called double Basilica procedures. They are more complex to perform. Here is an example. In order to do a double Basilica, you need to have 4 catheters. 2 catheters they are designated for each leaflet. This is the laceration of the left cusp, followed by laceration of the right cusp, and this is followed by the TAVR procedure itself. And now we understand that we need to focus on a certain leaflet. So if we need to lacerate a certain leaflet, we need to understand how to view that leaflet, how to orient to that leaflet. So basically, if we want to lacerate the left cusp, we have 2 basic views in how we image that leaflet. When we look at it like that on FAS, this is, we call it the front view of the leaflet, in which we see the leaflet from one side of the screen to another. If we look at it from this view, this is the side view in which we see the leaflet only as a line that goes up and down. And these both views are very important for us to define the leaflet, how it behaves in space along the perpendicularity plane of the aortic valve. And we know that the perpendicularity plane of the aortic valve looks like that. It goes from aleocranial to areocaudal. And basically along that perpendicularity plane, we can see the side views and the front views of each leaflet. And basically for left cusp side view, it is in aleocranial. The left cusp front view is in areocaudal. The right cusp front view is in around AP, and the right cusp side view is in severe areocaudal or severe aleocranial. Another significant consideration when we talk about the Basilica procedure is coronary ostial eccentricity. The location of the coronary ostium towards the leaflet, and whether it comes towards the middle part of the leaflet or eccentric towards the side of the leaflet. If it comes towards the mid part of the leaflet, this is easy and It's a conventional basilica in which you want to tear the center part. If the coronary ostium comes towards the side of the leaflet, then you may consider doing an eccentric cut. So I'll describe some clinical data regarding basilica, and the first thing is from an important registry in the US, an IDE study, prospective registry of 30 patients performed in 4 different centers. And basically we can say that the basilica technique, at least in experienced centers, is a technique associated with good outcomes. Survival was 100% in these 30 patients, and freedom from coronary obstruction was also 100%. There was no coronary obstruction in none of these cases at risk for coronary obstruction. Now we tried to do the basilica more and more in unusual scenarios, and one of these scenarios is the TAVR devices that come for valve-in-valve themselves. For instance, core valve devices, there are other devices as well, that fail and come for valve-in-valve. These leaflets commonly go above the level of the STJ and put the patients at risk for coronary obstruction. Here you can see an example of a double basilica performed for core valve at risk for coronary obstruction. You can see the left and right cusp lacerations that is followed by valve-in-valve. You can still see that in that case, I've performed the right coronary protection with a wire and left coronary protection with a wire, just because we were not exactly sure whether the basilica is effective. Now we know that it is effective. And after the valve-in-valve, we see that there is flow maintained to the left main and to the right coronary artery. We also know that the basilica is not free from adverse events. Here are a couple examples of complication and adverse events that can happen. The most common thing is lack of efficacy, or the fact that we are not able to traverse the leaflet easily, like you see here. But there are, when you start to manipulate wires after they are being electrified, they can go to places, or they can go to the not intended place, like go around the ring of the surgical valve, not through the leaflet. Here's an example of aortic RV fistula. It can go through the aortic mitral valve curtain. These are rare events, but when there are hundreds of basilica cases, this can happen. Here's an example of a mitral apparatus loop that can happen. You need to be careful not to damage the mitral valve when you do basilica. And the rare events in which we had a LV hematoma and a coronary artery dissection. These were all managed in follow-up. You can see other events or technical considerations, laceration of the guide catheter that was uneventful, and the guide catheter invagination, and other technical issues related to the basilica. So the basilica is a technique that need to be taught carefully. There are steps that it's better to use a proctor when you do these cases. It's when you do it in a very methodological fashion, it is safe, but it is complex. One of the concerns with basilica is that the lacerated leaflet can break into parts, and some of them would embolize. And we see here an example of a part of a mitral flow leaflet that we grabbed in a sentinel basket later on. I do advocate for using neurovascular protection when we do basilica procedures. Here is a devastating complication of basilica, and one of a kind. I don't know of another complication like that. sending a aortic root dissection that was caused by the a traversal leaflet oriented not to the proper location. Coronary obstruction after Basilica can still occur. This is an example from Germany. We can see that still there was left main obstruction after the Basilica that needed to be recovered with a stent conventionally. I will skip to a related procedure that is aortic root tricuspidization. It is a growing approach. We know that we have many bicuspid valves coming for TAVR, and these valves, when you do TAVR inside them, do not expand well, especially when you have a calcified raphe in type 1 bicuspids. And if we lacerate along the raphe, para-raphe, then we will be able to have better expansion of the TAVR device and fortunately better durability. So here is an example of a traversal of the leaflet in a very specific location in order to create tricuspidization, to make a bicuspid valve tricuspid. And here is the laceration of the leaflet. Basically, it's clearly related to how we do Basilica procedure. Basically, our aim is to have afterwards a nicely expanded TAVR device that will not have paravalvular leakage. Here's another example of a laceration of a leaflet before we do the TAVR procedure. This is a highly calcified leaflet. It's quite amazing that we are able to lacerate heavily calcified leaflets with electrified wires. Let me show you a couple of slides on a registry that we presented in a PCR, which is basically the largest registry today that we have on the Basilica technique. Basically, a registry of 129 Basilica procedures. Here you can see some clinical data related to these patients. Average age was 75.7, and the high-risk patients, we compared them to conventional patients in the VIVID registry that required aortic valve-in-valve. You can see that 2/3 of the Basilica procedures were performed using Evolute and core valve device Evolute and Evolute Pro mainly, and about 1/3 with the SAPIEN devices. We tried to match these Basilica procedures with the control cases at risk for coronary obstruction, having a similar degree of virtual THV to coronary distance, or VTC. And basically, we see that the clinical outcomes were mainly inferior in cases having double Basilica, having a need to lacerate both the left cusp and the right cusp before you do the TAVR procedure. Here you can see that in survival curves, patients that came for single Basilica had a quite good survival within a year, but those having double Basilica and those having that were control cases from the VIVID registry had relatively poor outcomes, especially when we talk about early outcome. So much inferior to single Basilica procedures. Also, when we look at survival free from stroke or coronary obstruction, in almost half of the cases having double Basilica or control, the results were quite poor. So single Basilica is great. When you do double Basilica, when you have two leaflets at risk, you may consider doing Chimney or stent protection for one leaflet and to do Basilica to the other. Or you may want to think about other strategies like sending the patient to a high-risk redo surgery in order to have a better outcomes. So in one slide, I'd like to summarize the topic and the field of coronary obstruction after TAVR and how we can prevent it. coronary obstruction is clearly a life-threatening complication that we need to identify before the procedure, and we need to prevent it. We have different tools to do it. We have basically the chimney or the snorkel technique, in which we have an undeployed stent waiting in the coronary tree. We do the TAVR procedure, we pull the stent and we deploy it in order to deflect the leaflet. However, that approach is suboptimal, and we have the Basilica technique. The Basilica technique is performed with splitting the aortic valve cusp that may cause the coronary obstruction. Hemodynamic instability after we do Basilica is relatively uncommon, fortunately. And Basilica has been applied in many hundreds of patients to date. There are major adverse events, but these are rare cases. And basically, I showed you the bad cases that happened along in different centers. It occurs in both. We can do Basilica to bioprosthetic valves and to native valves. We can do it to double leaflets, although with inferior outcomes. And we can use different types of TAVR devices in order to perform the TAVR after the Basilica. And Basilica may have value in the future to enable tricuspidization to lacerate near the raphe in selected cases that you're concerned about the expansion of the TAVR valve after, and you are concerned about the durability of the procedure in selected cases. And Basilica could potentially be the preferred therapy in patients at risk for isolated single vessel obstruction in TAVI, but the optimal therapy for patients at risk for double coronary obstruction is yet to be determined. You may consider doing, like I said, chimney or snorkel technique to one leaflet and Basilica to the other leaflet. And if you're highly experienced in doing Basilica, you may consider doing a double Basilica procedure. So thank you very much for your attention, and I'm here to answer your questions. Thank you.
Thank you, Dr. Dvir. So very nice lectures. I'm very impressed in the many Basilica case and experience. Because of limitation of time, Dr. Dvir will have the 2 questions from audience and panelists.
Can I ask the first question? Dr. Dvir, do you have experience on using J-valve with a different anchoring mechanism to prevent coronary occlusion?
Well, I did use a similar, not exactly the same TAVR device, but I used Yeung valve in certain cases at risk for coronary obstruction. Well, basically, there are 3 TAVR devices. One of them is not with us anymore, that can clip leaflets. And by clipping the leaflets, you can prevent that dislocation of the leaflet that can cause an obstruction. We had in the past the engager valve, and in recent years we have the Yeung valve in 2 versions, and we have the J valve. My concern is that it is less predicted how that leaflet will behave later on. It is true that in certain cases, in borderline cases, leaflet clipping can prevent an obstruction, and we did see that, but I feel that it is less predicted, and coronary re-intervention, going back to the coronary tree, can be challenging when we compare to Basilica. Basilica can enable going back to the coronary tree easily. One of the advantages of doing Basilica in comparison to clipping the leaflet is that the flow in the coronary route, in the aortic route, is much more natural. We have a lot of bench testing that suggests that probably leaflet thickening would be lower, and it is more healthy to the aortic route to have a laceration of that leaflet. But it is true, like you said, that the J valve and the Yeung can, in borderline cases at risk for obstruction, can make a difference and can prevent that obstruction.
Thank you.
Danny, can I ask, you mentioned about native aortic stenosis. We know a lot of the, especially the bicuspids, are very, very calcified. especially in Japan, in China. Is there any limit of the calcification that would prevent you of using this technique in which the failure rate might be higher than the usual cases?
It is true that when you have severe calcification, then in certain cases it could be more challenging to traverse the leaflet,
Right.
especially when you are not oriented to the leaflet properly. So imagine that I have a leaflet here, and I stand towards that leaflet with a catheter. And when I electrify a wire and I'm perpendicular and I'm coaxial to that leaflet, then I have all of my energy concentrated, and in many cases, the wire find the way to traverse it. But if I'm not an experienced Basilica operator, and my catheter is not perfectly coaxial to that leaflet, mildly in an angle, and that leaflet is heavily calcified, like in your question, then that combination can make it challenging to traverse the leaflet. So in calcified leaflet, you need a bit more experience to stand properly behind the leaflet in order to traverse it. It is true.
Thank you, Dr. Dvir. So I'd like to move to next session. Definitely, we will have time for further questions after all lecture will be finished. So the next speaker will be the Michael Lee from UCLA School of Medicine, United States. He will talk about the MCS-supported complex PCI. Michael Lee, please.
Great, Dr. Ahn, thank you for inviting me to this session, which includes some very experienced and skilled operators. So my case involves an 81-year-old male with a history of hypertension who had a cardiac arrest during coronary angiography for a newly diagnosed cardiomyopathy and was referred to our center for further evaluation and revascularization. So here's his EKG. He has baseline atrial fibrillation, intraventricular conduction delay. He has anterior as well as lateral Q waves and poor R rate progressions in the inferior leads. So here's his echocardiography. You can see that he has biventricular LV as well as right ventricular, left ventricular systolic dysfunction. Ejection fraction is 20%. You can see the aortic valve is heavily calcified. The aortic valve area is 1.2. He had moderate tricuspid regurgitation and severe pulmonary hypertension. You can see the right atrium as well as the right ventricle are dilated. TAPSE was 10, suggesting severe RV dysfunction. So we took him to the cardiac cath lab. We decided to perform transradial intervention. The cocktail included 200 mics of nitroglycerin and 4,000 units of IV or IA heparin. He became profoundly hypotensive with that cocktail, probably from the nitroglycerin. He also received some gentle sedation with fentanyl and Versed. At this point, the patient became hemodynamically unstable. We had to do a mechanical support device. He also was bradycardic, required insertion of a temporary pacer for bradycardia. Just to obtain hemodynamic stability, again, the impella was implanted through the right femoral groin. It provides non-pulsatile flow. Basically, it unloads the ventricle, increased coronary perfusion, as well as cardiac output. So you saw the right coronary angiogram. He had a severe osteostenosis as well as a chronic total occlusion starting from the mid-right coronary. He does have good collaterals from the left system, and he does have a severe distal left circumflex artery, and he has a heavily calcified proximal LAD. So let's talk about this patient. So in summary, this is an 81-year-old male with severe biventricular dysfunction and multivessel coronary disease. He was referred to our hospital because he was deemed to not be a surgical candidate. He was volume overloaded. We tried to diurese him, and upon our angiography, he became unstable, which required a mechanical circulatory support device. He also had severe coronary calcification with an occluded right coronary artery and severe circumflex disease. So moderators and panelists would appreciate your thoughts.
I think this case is a very complex case. It's a good choice to use impeller support before we're going to do the PCI. Just by the angiogram, we can already see that the calcification in AD is very, very severe. So probably you need, again, a atherectomy device.
Yes, you can see the severe coronary calcification of the proximal LAD when we did the
And also outside, yes.
So how was the hemodynamics after impeller insertion? It was become stable or still unstable?
Yes, so he did improve his hemodynamics. It went up to about 85 systolic. With the blood pressure with 85 systolic, it was better. We did not start any inotropes. We thought, as opposed to giving pharmacotherapy, unloading the ventricle in a map of about 65, 70 was much of an improvement compared to 50 when he became unstable. If I could ask the panelists, in Korea, if Impella is not available, what devices are available? Would you use a balloon pump or ECMO at this time?
Balloon pumping is available and also ECMO is available, but Impella is still not available in our country, unfortunately.
I would use ECMO for this situation because the patient is not only have the AV dysfunction, but also has the RV dysfunction, and the respiratory failure can be occurred, and ECMO would be a good support for this kind of patient.
And for this case, the RSA seems is like a CTO. Maybe if you want to save the vascular access, maybe you can try single access of the impeller to do the contralateral angiogram to guide the PCI on the RSA. Is it the story going like this?
So our initial plan was not to do a mechanical support device, but rather just do the intervention radially. But did not anticipate him having such a significant response to intra-arterial nitroglycerin as well as gentle sedation.
I think for such a complex case, triple vessel disease calcified with depressed LV-RV function, I think Impella is definitely a good choice. The problem with the ECMO, probably for me, with the ECMO, you can support the hemodynamics, but you are going to increase the afterload, and then you will make the LV function even worse. So if I have a choice, I would go for Impella instead of the ECMO. But of course, if you don't have other choices, you don't have the Impella available, ECMO is probably a good choice. I don't think balloon pump is going to be enough to support this patient. And probably I will concentrate on the left side intervention, both the LAD probably requiring some atherectomy, and then the obtuse marginal. I would probably the left wing bifurcation is okay. So I would see the condition at the end of the intervention to the left side and decide on whether I would take on the CTO lesion over the RCA at the same session, or to stage the patient to come back for stage PCI to the right RCA.
Yeah, I couldn't agree further. The deleterious aspect of ECMO is that it does increase afterload. And in such patients, you want to decrease afterload, you want to unload or vent the ventricle. In patients such as this, if we did not get an improvement in hemodynamic stability, then combining ECMO with Impella is an option. It does become quite an expensive technique, but Impella does supply some hemodynamic support, but in patients that are in extremis with blood pressures in the 50s, especially in the setting of acute myocardial infarction, we actually do both to unload the ventricle as well as to obtain hemodynamic stability with severe aortic blood pressure compromise. But it's interesting in countries like Korea, for example, where Impella is not available, that they're able to do such complex cases in patients with severe hemodynamic compromise with ECMO, and patients do reasonably well.
So, Dr. Lee, can I ask, In America, if we plan to stage procedure, will you use impeller again if you want to compete with us like in the RSA? Or usually will you, if you are, because the impeller is very expensive, will you try to open all the vessel in the one procedure when you have the impeller support? What is the usual practice in USA?
I would say case-by-case scenario. The circumflex, it's a focal lesion. There are many branches. There's a big ramus branch. So that intervention should not be too difficult. The right coronary, it's a complex, long calcified, diffusely diseased vessel, but it depends on the patient's baseline hemodynamics. We do right heart catheterization, look at cardiac power output, pulmonary artery pulsatility index, get a mixed venous, just to get a sense where his baseline hemodynamics are. And if it looks like a straightforward intervention and doesn't have a CPO that's low and a mixed venous, let's say in the 60s, perhaps it's straightforward to do. But I would say it's just by case scenario.
Okay, Michael, go ahead, and due to time limit. Okay. So
briefly, I wanted to mention this technique where when you're doing a complex case and maybe it's very difficult to advance a wire, once you get the wire through, it's very vital that you not lose wire position. So when I did live cases in Asan, I had the fortune of working with some very skilled operators, so they never pull the wire back. But this is a technique that I use when my assistants are not very skilled. So once I have the wire in, I actually put the device close to the TUI bores, create a loop with the shaft, and as I'm advancing with my left hand, the shaft, I'm just pulling back the wire. So it becomes a very good technique for, let's say, assistants who do not have a lot of experience in helping out and assisting with atherectomy. So it's just something to consider, what I consider the single operator technique. Now, previously, when the panelists had mentioned the diffuse calcium required atherectomy, this is absolutely the case where you don't want to balloon dilate, you go high pressure dissect, and it becomes a situation where atherectomy is off the table. So now you have hemodynamic support with a mechanical circulatory support device. You pass the wire down, you have orbital atherectomy, and this has become my device of choice. And this has several advantages compared to rotational atherectomy. If you look in this panel, look at this 1.25 burr. Once it goes through, it will just sit on the greater curvature. It won't really touch the lesser curvature. Whereas with orbital atherectomy, not only does it rotate, it orbits. So you'll get 360-degree contact. So as you spin, you will have contact, you will debulk and atherectomize, plaque modify, and when the vessel is at least 3.5 millimeters in diameter, I will go high speed, which gets you about a 1.75. The beauty is you do not have to exchange. So think about if you cross that lesion with a 1.5, but that's probably not enough debulking or plaque modification. You don't have to take the device out with rotablator, disconnect, reconnect, and go back in. This is much faster. So just pushing one button, you could get atherectomy similar to a 1.75 millimeter burr. So after we perform orbital atherectomy, I leave the 014 Viper wire down, and it has the support of a roto extra stiff wire. So it helps like a buddy wire. Now, if I'm able to advance a workhorse wire like a balance wire, it tells me that the lesion is adequately prepared. I'm not in the dissection plane. So I always leave that buddy wire, the Viper wire there as I'm doing pre-dilatation. So this is just straightforward 2.5 30 millimeter balloon dilatation. You can see here that the balloon fully profiles. And at this point, the intervention becomes very straightforward. This is a 2.75 by 38 Zion stent. We overlap with a 3.25 by 38 millimeter Zion stent. We perform OCT, and the reference vessel diameter in the Prox LAD was 3.5. So we go high pressure with a 3.5 by 20 millimeter non-compliant balloon. The patient did well with hemodynamic support. we titrated down on the support, and once the patient got down to P1, we're able to wean off Impella. Since we had contralateral access, we did not have time to put in 2 pre-closes to help hemostasis. So what we do is we take the Impella out through the sheath, and then we direct a wire to the side of the arteriotomy in the right femoral artery, and we get ready with a peripheral balloon, let's say a 7 by 40 millimeter balloon, to help achieve a hemostasis with manual compression. The patient did well. And he left the cath lab with a TR band and complete hemostasis with in the right femoral artery. So some of the discussion points. This is a patient who had complex, severely calcified multivessel disease, including the LAD. He was not considered a surgical candidate, and the role of mechanical circulatory support device. Any thoughts on the moderators and panelists?
I think totally this approach is a very standard approach. For the point whether Diamondback is better or water beta is better, I think in the old day, Diamondback is definitely were better because more easy to use. But nowadays, if the water pole, if we have the new version of water beta, is also very user friendly, and I find it's not bad at all. And then if there's any problem, then we can also use shockwave. If the calcium cannot be completely cracked, there's always, I think, is operator's preference. No absolute answer unless there's head-to-head comparison.
One potential advantage of orbital atherectomy is that, unlike rotational atherectomy, where you're basically going down one plane, because it orbits, I think there's less no reflow phenomena because you maintain coronary perfusion, in my experience.
Yeah.
I agree with Michael that rotational atherectomy probably is very effective in creating a small lumen. It's not going to give you a big lumen, especially in this very big LAD, big vessel. So I think orbital atherectomy might be a better choice here when you encounter big vessels and doing more atherectomy than the rotational atherectomy. Yeah, the other option obviously we have in Hong Kong here is the shortwave lithotripsy balloon. Sometimes you might combine the use of rotational atherectomy together with the shortwave lithotripsy balloon, especially for the big vessels in which the rotational atherectomy are not going to create a big enough lumen for us to do the a good stenting procedure at the end of the procedure. Yeah, that's how we will handle severely calcified big vessels here.
Shockwave is a great device. It is able to profile at low atmospheres, even at 4 atmospheres, the balloon profiles. One of the limitations, however, is the crossing profile. So many lesions it's not able to cross. Now, if you combine atherectomy with shockwave intravascular lithotripsy, it becomes quite costly. So
yes,
that's one disadvantage of using combined lithotripsy as well as atherectomy. But in select cases, I think it's very reasonable to do.
Well, especially for those like subtotal or lesions that you can only get a wire cross, sometimes orbital atherectomy might not be easy to get through that very calcified tight stenosis. Rotational atherectomy might be a little better in crossing those lesions. Those are the times that I think combined rotational atherectomy together with another shockwave balloon might help the procedure a lot more than the orbital atherectomy.
If you use rotational atherectomy, you would probably use a 125 burr, correct?
125 or 1.5, yes, small burr. Yeah.
So
usually 1.5.
Yeah, 1.25. I have seen cases. There are case reports where if you cross, because the diamond chips are on the crossing distal portion, sometimes I've seen burr entrapment. So that's the one concern when you're using the 125 burr.
That might sometimes happen. You're right.
Yeah, I want to add one more point. I think totally this case you have very good mechanical support. The other drawback of diamond bag is that you need to move very slowly, and then in very tight lesion, sometimes you will get prolonged occlusion. If you don't have good mechanical support, sometimes the patients will also collapse, not due to no refill, but due to obstruction of the coronary. However, if you have impeller support, then maybe it's okay. It's a good choice in this sort of situation.
Absolutely. They recommend 1 millimeter per second, whereas with rotational atherectomy, I've seen people go much faster back and forth like a windshield wiper. But you can't do that with orbital atherectomy. You need to move very slowly.
For closure of the impeller sheath wound, sometimes we will pre-close if possible, but if not possible, sometimes we can use a mentor at the end of the procedure actually to close the big bore wound. I don't know whether it is available in the US because we use quite a lot of mentor device nowadays to close big bore sheaths here in Hong Kong.
We don't use a lot of mantra. Let's say for TAVR, for example, our standard technique would be to do 2 pre-closes. Just because the patient became unstable, our initial goal was to just put the device in as soon as possible without thinking about putting in 2 pre-closes.
Right.
Michael, very hot discussion, but please go ahead.
So, in summary, plaque modification with orbital atherectomy can be performed for severely calcified coronary arteries, and mechanical circulatory support can be used in patients with severe LV dysfunction, who undergo complex PCI, including coronary atherectomy, and provides a sense of relaxation and calmness for the operator. We're able to focus, take your time, and do optimal PCI technique.
Okay. I think we due to time limit, we're gonna move to the last special lecture. Okay.
This lecture will be the complex PCI, the post-TAVR implant. Dr. Alan Yeung, please.
Thank you, Jung-Min and Jung-Woo for having me give this lecture, and thank you for continuing to educate and train during this difficult time. And I think the complex PCI will continue to contribute significantly to all our colleagues. So my topic, complex PCI post-TAVR. This is my disclosure. So we all know that because of the patient population being evaluated for TAVR, the coronary arteries prevalence is quite high. So a lot of different trials have monitored that, and possibly affecting about 80% of the cohort of the patients that we're considering for TAVR. The question is therefore, when we diagnose there's presence of significant coronary artery disease, what should we do? Do we beforehand start to have the coronary treated first? So that means usually separate trips for the patients to the hospital. The plus is that you can spend more time, devote more completely to the PCI procedures. The minus is that this is another procedure, and potentially because the AS is untreated at that time could make your complex procedure more difficult. The second option could be during the TAVR procedure. So this is convenient for the patients. So the plus is that it's simpler for patients, address supply and demand at the same time. And you can support the patient easily if you need to, because all the equipments and so forth are there. The minus is that there's more contrast, there's time, there's DAPT preloading, and potentially could lead to more bleeding. And also you can do it after the TAVR procedure, and maybe to sort of see whether the angina could be due to the AS, and therefore once you relieve the AS, the angina has resolved. But at the same time, because now you have a valve frame in the root, and therefore could be very unpredictable in whether you can access the coronary and making the procedure more difficult. So let's just take a look at one example of a patient and see whether, during the procedure of TAVR, how do we sort of treat complex coronary disease? So this is a typical patient we see in the US, old patient, 87 years old, and has bad lungs as well, oxygen-dependent COPD, has dyspnea on exertion, has aortic stenosis with a mean gradient of 40 millimeters of mercury, normal ejection fraction. You can easily see there's heavily calcified coronary arteries, and there is a distal left main stenosis with a bit of disease in the proximal LAD. The right coronary has some calcium as well, but has some diffuse irregularities, but no clear bad disease, except maybe near the PDA, there's some moderate disease as well. So the question is that if you look at this AP cranial view, clearly show there's a distal left main stenosis. The question is that do you treat it first, bring the patient in, get the left main taken care of, whether it's 1 stent, 2 stents, or combine with TAVR, or treat after TAVR. The patient had dyspnea on exertion, no clear angina. The difficulty is obviously as an elderly patient, and it's actually she lives pretty far away and pretty difficult to get her to the hospital. So therefore, we decided to perform this procedure just before we do TAVR. So this is a calcified lesion. We performed rotational atherectomy, and we actually did an MLA measurement. And I think this is done before the rotational atherectomy. It's 2.9 millimeters square. The circ origin on a side view looks clear. We didn't spend the time to look at it separately in the circumflex, given that this is sort of hopefully a quicker procedure before TAVR. And then we basically place a stent in a crossover fashion into the LAD and post-dilated with a 3.75 NC balloon, while it's in the circumflex to protect it. But you can look at it carefully. There's actually some lesion in the circumflex just after the takeoff of the circumflex. So we checked an IVUS at the end. The MSA is greater than 10 millimeters square. This circumflex has good flow. There's a slight worsening of the area that is not at the origin, but just maybe 3 or 4 millimeters beyond it. But given that this is an elderly patient and we want to go on to TAVR, we actually leave that alone. So we put in a 23 millimeter S3, pretty straightforward, no gradient afterwards, and 30 days follow-up has a gradient 9 millimeters across the valve, no PVL, and symptoms must improve. So it shows you that, you know, when you want to do complex coronary disease before TAVR, sometimes you have to make the procedure a little quicker, maybe a little bit less than ideal. For example, in this case, if I do it separately, I may IVUS the circumflex, may treat the circumflex and with a stent, maybe not jailing the origin. So many options, but I think given her age and other disease, that LAD crossover stent is adequate. So how about in many patients, they might have coronary disease afterwards. So what do? We know that this may happen, but actually the incidence is not super high, meaning that post-TAVR, you know, we're not planning to do PCI, but the patient come back subsequently with coronary disease progression. Various studies has put the incidence to be about, you know, from low incidence of almost less than 1% to almost about 6%. And these fair number of them are ACS indication. Obviously, the timing is quite variable, usually within the first year or so, which is not unusual because that you have just did a coronary angiogram and felt that you don't need to treat anything, or they are moderate lesions. The issue, obviously, as you all know, is that to reaccess the coronary arteries through the TAVR valve frame could be challenging. And this is showing the evolute valve, and there is a bunch of dimensions listed here that has some relevance. Just to highlight a couple of things is that the sinotubular junction diameter is important, number one, because if it's very small and the valve is high, it could have a difficult time gaining into the sinus and therefore gaining access to the ostium of the left main or right coronary artery. Another important measurements is the leaflet height, because if the leaflet height, just as Danny talked about, is very high and the sinus is small and short, you could actually jail near jailing the sinotubular ridge and getting access into the sinus and the left main again could be difficult. And obviously the distance from the native aortic leaflets, including the bulky plaque, lesions in the valve itself could be very close to the left main and making access difficult. And again, the skirt, as you recall, is pretty high in the evolute valve, and therefore, if it's implanted very high, it could actually block off the coronaries as well. So these are some of the measurements that you should be aware of in terms of the various size of the evolute R and Pro valve. And one of the more important numbers is the skirt height. And they are all 13 except the 34 evolute R is 14. So you can imagine if they're very low coronaries and then the valve is implanted relatively high, they could be basically covered by the skirt, and therefore very difficult for you to get access from inside to that coronary. The ways on the top on B, again, we talk about the sinotubular ridge junction, but hopefully because you put the TAVR valve in, your original CT shows that there's an adequate sort of diameter in the sinotubular ridge, therefore should not be a problem. So what happened if you put a valve in to the coronaries? You can see that if you are actually in the area that doesn't have the commissure, meaning, as you recall, the evolute valve has a commissure as marked by this little tab C, which is on the opposite end of this view, and there's two more on the side. So if you are implanting somehow in a lucky fashion, that the low part of the suspension of the valve is actually towards the left main, for example, and therefore you have three areas you can potentially choose from. But unfortunately, if you have the commissure of the new TAVR valve is actually against the origin of the coronary, therefore now you have to gain access from the other side holes to the left main or the right coronary. This obviously becomes more challenging. The S3 valve is a little easier because it's shorter, and typically the skirt height is a little shorter as well, and therefore you can gain access usually to the left or right coronary artery through the open cell on the top. Again, the dimension here is that the B is the inner skirt height, obviously different size of the SI, the S3 valve, typically up to about 10. So you can remember that being 10, 11 is the height inside, and anything above that will be through this clear big cell. So what do we do if we need to do PCI after TAVR with the evolute R valve? This is a little flowchart published earlier, and it basically shows you that you need to gain access to the sinus through the cells, and then ideally you would get it through using a J wire directly through the cell into the sinus first. And sometimes that could be difficult, and you would use a stiff angle glide wire. And again, if you want to get access, femoral is easier. Also, if you want to prefer radial, the left is preferred because you need to gain it in without much sort of bending of the guiding catheter. So remember, if the commissure is posted right in front of the coronary ostia, and you have to think about that, you need to get in potentially from side hoses. So therefore, you should use an FL guide, therefore allows you to actually move it a little bit without sort of have this long arm of extra support guides such as EBU that you need to sort of get into some of these cells much harder. And the right coronary just use an FR4 guide. If the post is away, you have a little bit more choice, but we generally just still use the FL guide for the left and then the FR guide for the right. For the SAPIEN valve, typically you can again do radial left and right here because it's not as crucial. You can use a usual EBU or various support guide and pretty much do it in a similar fashion. Just beware that in case your coronaries are very low, it could be underneath the skirt and they might be a little bit more challenging, and should be prepared for that. So recently there is an article published in JACC Coronary Intervention, I think just this week or last week. And basically this is the reaccess study, basically looking at 300 patients and from approximately close to a year, and essentially showing that if you want to they basically study after the TAVR, can you get into the coronaries? There are 23 cases that they could not get into the coronary cannulation after TAVR, and 22 out of 23 of them were the evolute R Pro valves. And you can understand that from my previous discussion, that could be a challenge at times, especially if you're not sort of skilled or looking at what you need to do. So what are the predictor for the difficulty getting into the coronary ostia? So if you use the evolute valve, it's harder. And if you have implantation that is very shallow, so the skirt of the evolute valve is high up and the coronary is low, you can make it difficult. And also if your sinuses are kind of small, there's not enough room for you to really get around and be able to manipulate the guiding catheter to get in, could be very difficult as well. So this is an example of a patient. So this is another 86-year-old woman, vascular path, unfortunately, has been treated with coronary disease in the past, in the LAD you can see, and various peripheral vessels as well. Has pretty high mean gradient on echo, normal LV function. This is the pre-op angio before TAVR, and this is in January 2016, and a 26 millimeter evolute valve was placed. This was chosen partly because his vessels were very small in the periphery. So she did well, but 4 years later, in January of 2020, has recurrent angina, and this was sort of presented as ACS. This is actually quite interesting. You can see from the injection of the sort of near the coronary ostium, there is this bulky leaflet that is sitting right in the sinus, and therefore gain access to the left main will be somewhat tricky. And the left main looks like has progressed in terms of disease. Different view, the left main clearly has more disease, and there's also in-stent restenosis in the proximal LAD as well, and some distal LAD stenosis further down. So my colleague treated this lesion in an ACS setting, and obviously using a JL type of guide, and to gain access behind this valve frame using a JL FL guide is difficult, and typically you need a guide liner to extend your guide, which is one of the technique essentially is to get the guide into the cell, and then the wire in, and then guide liner in. And then he basically stented the left main, and unfortunately, once he stented the left main, he had a very hard time getting further things down into the LAD, and therefore he just did a balloon dilatation of the in-stent restenosis of the LAD. So this is the final picture. Left main looks better, and the balloon dilatation of the in-stent restenosis is adequate. But you know that that probably won't last, because these ISR with balloon itself is likely to recur. So 5 months later, no surprise, the patient has recurrent angina, and the EF actually has decreased, and you can see the in-stent restenosis is worse. So again, now we're left with the challenge in trying to get into the left main with a stent sticking out, with difficulty getting into the ISR. So this was quite difficult, and I basically have to use buddy wires, get multiple wires in to really be able to get around the origin of the stent in the left main, making sure the wire is coaxial or inside the lumen and not around the stent. So we were able to get 2 wires in, and one basically will not let anything go through, presumably that is outside the left main stent, and the other one is allow us to have small balloon in. So basically we use microcatheter at this point because it helped us to support the system, and use a small balloon subsequently dilated the in-stent restenosis. And then we stented the ISR, which were a little challenging, but it's actually we were able to do that with, again, a guide liner support. And then optimize the left main, and then check at IVUS as well, and making sure everything is okay. She has a lot of distal disease. We're not going to tackle that because she has all that stuff before the TAVR as well. The patient so far has done well, has not returned back to us for any further angina. So in summary, treatment of coronary disease before, during, or after TAVR. Before, I think for complex lesion, you need to spend a lot of time on, I think, for example, using rotablator. I think a separate procedure is warranted unless the LV dysfunction is concerned and you would concern about the aortic stenosis not addressed in the same setting. If the LV function is pretty adequate, I think complex lesion, devoting a full time to get that done, especially in younger patients, I think is warranted. During is the majority of lesions, unless it's asymptomatic, I would say if it's symptomatic, defer. But if you have ambiguous symptoms, I would treat. But if you have planning to do a self-expanding valve, I would treat as well, because treating it after could be quite difficult. And obviously complex lesion with hemodynamic consequences, I would treat as well. Afterwards, it's only really for new lesion, progression of old lesions, and learn how to access to a TAVR frame is very important. But also in many of these coronary disease, we see many of these lesions, and many of them were not tested physiologically with FFR, for example. And one question is that, can you treat many of these lesions medically too? So there's a trial that is actually being organized right now. It's called Complete TAVR, sort of based from Vancouver. Essentially, is looking at for patients that have undergoing TAVR, they'll randomize if they have significant coronary disease to complete revascularization after the TAVR or undergo medical therapy. There's a lot of sub-studies in terms of what other anti-thrombotic agent they should use, and to be followed for about 3.5 years. This is looking for about 2,000 patients, and we are just in the stage of planning this trial. So thank you very much, and happy to take any questions.
Okay, thank you. Okay, go ahead.
Thank you, Dr. Alan Yeung. Your presentation is, as always, very informative and very educational. So do you have any question from audience, panelists? And
I ask one question for Dr. Alan Yeung.
Yeah.
When considering the younger patient with longer life expectancy, would you choose balloon expandable valve instead of self-expanding ones?
I think the two valves are, in terms of the longevity of the leaflets, I don't think there's any trials that show that they are any different. The major sort of for us is to decide whether there's any conduction disease already. So obviously, the self-expanding valve have a little bit more higher pacer rate. So if they have right bundle branch block, left anterior hemi block, and so forth, we tend to use balloon expandable. And if you are have a lot of peripheral vascular disease, we like to use the self-expanding. So I think for younger patients, if you are looking at it, they might need a second valve, meaning a TAVR valve in a TAVR valve 15 years down the road. The first valve going in could be more balloon expandable, right? Because it's a little simpler, sort of surgical, almost like a surgical valve. And then you will lay on top of it a self-expanding 10 years later. So you have so because putting in about balloon expandable in self-expanding is a little more tricky. Where exactly you want to put the valve, and then could be affecting the coronaries, as Danny showed a case earlier. So I would say if you think the patient's longevity will require two valves, and since you're doing the first TAVR, most likely you try to do the second TAVR as well, is to put in a balloon expandable.
Ellen.
Yeah, hi, Michael.
Great lecture as always. Can I just ask you, for patients with very tight aortic stenosis and then severe coronary artery disease, before we do PCI, how often do you need to do a BAV procedure before the coronary intervention? Because sometimes when we encounter difficulty in coronary intervention, patient crash, it's difficult to resuscitate these sort of patients with severe aortic stenosis.
So I think there's three factors playing a role here. So you look at LV function, right? Because if the LV function, the gradient could be very minimal at that point, 30.
Right.
But your LV function is gone, meaning that this is actually a burned out ventricle, and the AS is actually with a V1, V2 is actually, it's a low output situation. I'm more worried about that patient population also. The very high gradient, mean gradient of 80, that's also a little tricky, right? Because, anything, changing a little something could tip the person over. So in those situations, I might consider doing a small balloon valvuloplasty before you cross the valve so that you are set to go. If anything goes south, you're ready to put the valve in and the big sheath is in, and you're ready to deploy the valve anytime. Then I'll go and fix the coronaries and then devoid the valve anytime, because even if your guides are sitting in the coronary and then you're doing your PCI, things are not so good, you can put your valve in, right? Because that's at least you know that you can do that. But I like to, if it's complex coronary disease, I like to kind of focus on it first and get it taken care of. But like this lady, you can argue, let's use two stents, crush it, do this, but it takes too long. And the longer you stay in the coronary for an 87-year-old with AS, the more likely you get in trouble. So you have to kind of balance it. At some point, you just say, look, I'm going to fix enough, but not perfect.
So Alan, so
Alan.
my last the comment to you lastly introduced the complete TAVR trial, but I'm still wondering the rationale and the study hypothesis of complete TAVR trial. You know, recently ischemia trial, medical therapy, OMT is okay, but this TAVR patient is different patient, the eligible, much fragile patient, the elderly patient, sometimes for complex coronary artery disease, incomplete revascularization would be sometimes reasonable for TAVR patients. So I don't know how they imagine the complete TAVR trial give some important insight to real world. Yeah.
Yeah, I think there's I have some sort of reservation about that trial because we're still deciding whether we want to participate. Because in a global sense, if you treat the patient AS already, you wait a certain amount of time, then you are asking a question similar to ischemia, right? Because just now you have coronary disease, and are they functional? Are they not? This trial doesn't even really mandate FFR, for example. Then are you really sort of just going back to the old question that there's coronary disease? What do you want to do? And medical therapy and PCI, I don't think you will show a big difference. To me, more importantly, is actually timing. When should you do the PCI, and also are these PCI important? So I think, you know, tying in physiology, for example, with the TAVR procedure, maybe, you know, do your TAVR right afterwards. You should check physiology and see what's going on and fix or not fix type of thing. So I think the trial is interesting, but at the same time, I'm not quite sure the result will be any different from ischemia trial, right? Because why would they, you know, in this situation somehow you fix the valve already. So the patient is actually, there's no gradient, right? So it's kind of more almost like ischemia trial again.
Okay.
Thank you, everybody. So very nice presentation. So thank you again. So I think Alan Young's presentation is the last presentation of this session. So I think this is the last session of this year, the complex PCI. So I'd like to ask to summarize this session and this year this complex PCI 2022. I'd like to ask to Dr. Park.
Okay, thank you. And so I think this session is maybe last session of the complex PCI 2020 virtual meeting. And this session is definitely we learn how to manage a complex situation in complex PCI TAVR and shock and something like that. I hope that everyone is going well in this COVID-19 resurge time. And definitely I would like to see you in person meeting in the next year. Thank you, everyone. Thank you.
Thank you very much.
Thank you very much.
Thank you. Stay safe.
Thank you. Thank you.
Goodbye.